to the Trauma-Informed Care in Long-Term Care conference call. My name is Anera, and I'll be the operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. During the question-and-answer session, if you have a question, please press star, then 1 on your touch-tone phone. I will now turn the call over to Ms. Toni Kettner. Toni, you may begin.
Thank you very much, and I'm so glad that people could join us. I would just like to say I'm the Nursing Home Project Specialist and represent Wisconsin in the Lake Superior Quality Innovation Network, along with our partners in Michigan and Minnesota. And I'd also like to give a shout-out to many of the Grade 8 members in multiple states that have been able to join us today, so thank you very much. I'd like to take this opportunity to welcome and to introduce Scott Webb. Scott is a trauma survivor himself who's worked in the behavioral health field for over 30 years. His career has included clinical, administrative, and consultant work. Scott's currently the Trauma-Informed Care Coordinator at the State of Wisconsin Department of Health Services, and I might add we are so glad that we have that position in this state. He holds a Master of Science in Education degree from the University of Wisconsin-Oshkosh and is a licensed clinical social worker. Since 2014, Scott has provided training and technical assistance on trauma-informed care principles to more than 7,000 clinicians statewide. His insights on trauma-informed care have been featured in articles published by the Wisconsin Center for Investigative Journalism and ISMUS. He has also presented at numerous conferences and acted as a keynote speaker for the UW-Madison School of Social Work and the National Alliance on Mental Illness Wisconsin Conference. Scott, I'll turn it over to you.
Well, thank you, Toni, and I really appreciate this opportunity to share my passion with everybody. Being in behavioral health for so many years, I wish I would have known all this information when I started my career back during the Reagan administration, because it would have been very helpful to me, and I think back with regret some of the people that I was entrusted to help and wanted to help, but because I didn't know a lot of what I'm going to share with you in the next hour, that I was less than effective as a helper, and I think I might even re-traumatize some folks inadvertently. So learning about this, taking it in, applying it to my own experience as a trauma survivor has been transformational in my life, and I'm grateful for the opportunity to travel the state and present on this issue. So I'm looking forward to spending some time with you today, just sharing my ideas, and hopefully you can answer some of your questions at the end of this presentation. I'm going to try very hard not to sound like an auctioneer, because this is normally a 4 to 6 hour training. So I'm going to try very hard to be articulate, yet succinct in my remarks, but I do tend to get excited and I might talk a little too fast. And I've got someone here to help me kind of guide me if I start talking a little too quickly. So I title my presentation TIC, Trauma-Informed Care, Trauma-Informed Connection, because one of the things that is very crucial when we look at trauma-informed care, trauma-responsive care, is that what we're trying to do is build healthy, safe connections between human beings. Because trauma is the disease of disconnection. And those who have had a lot of adversity and trauma in their life, they have a very difficult time feeling safe anywhere with anyone, and they have a very difficult time forming healthy relationships. So it's incumbent upon all of us as helpers, even if we're wounded healers ourselves, to get the help that we need so that we can recover and heal from our own experiences, but also to be able to be better equipped to be that person that can build those connections with those who are looking so desperately to form those type of connections. So what I would like to do in the next hour really is just define and identify some of the key terminology and concepts related to trauma. In my travels around the state, I noticed that people have somewhat of an idea of what trauma is, but they may not know exactly how it would apply to trauma in trauma-informed care. So we'll talk about that. We're also going to talk about the significance of adverse childhood experiences, which I call ACEs, and how it relates to mental illness across the lifespan. And then I'd like to have all of us come away from this webinar being able to articulate what trauma-informed care is and perhaps what it is not, and be able to identify the 5 pillars of a trauma-informed culture and how that culture can change for any organization, whether it be a school, a church, a medical facility, skilled nursing, whatever, that would be very useful and helpful in knowing exactly how can we apply these 5 pillars to trauma-informed care. A little bit about my own story. I'm a trauma survivor, and as a 16-year-old, I had a peptic ulcer based on a lot of the toxic stress I was living in as a child, not knowing that I was starting to build kind of the building blocks for later problems. And so we go back to 3.5 years ago, I suffered what's called a widowmaker heart attack. And that almost killed me. In fact, my doctor told me if I would have ignored the symptoms for just 30 minutes more, I would not have made it, because there's only a 6% survival rate of those who have heart attacks like I had. So that was a wake-up call. Then while I was in rehab, I'm doing some research, and I come across a couple of articles, much like what you see on the screen. One that says abuse and adversity in childhood is linked to more cardiovascular risk in adulthood, and that really resonated with me because I wondered why I have 4 heart stents in my 3 main coronary arteries, because heart disease does not run through my family. So what is that about? And then I found another article kind of related that said, what do asthma, heart disease, and cancer have in common? Well, maybe childhood trauma. So we're starting to understand, and this is what Dr. Vincent Switty, who's the ACE study investigator, said is adult diseases, and I'm talking about any adult disease going through the lifespan, can best be understood as the manifestations of distant childhood events. So when we start looking at people and their overall health, whether it be their physical health or their psychological health, hopefully we get to the point where we just reflexively will think about what happened to them in their childhood, because it's very common, especially those who are older, who look back at their childhood and say, no, I wasn't traumatized, I just had a strict upbringing. I'm sure if my parents were both alive, they would probably say the same thing. But when we look at the behaviors that they witnessed, or the experiences that they had, and we now know what that does to our brain development as children and what it does to our bodies, we begin to understand, looking through that prism of trauma-informed care and what we know about trauma and what it does to our bodies, is that ACEs are a real powerful thing, and that people are affected and continue to be affected dealing with things that they've never thought of before. So this is a presentation that can be somewhat triggering for folks. Even if I'm doing a 75-minute breakout session at a conference, inevitably I'll see somebody in the audience who I can tell is a bit uncomfortable with the topic matter, because this isn't something that's going to be about unicorns, rainbows, and lollipops. This is talking about trauma and adversity in childhood. So I just invite my audience to be gentle with themselves and do what you need to do to take care of you, because if you hear of anything today that you find upsetting, just remember to do some deep breathing and remember your self-empathy, some positive self-talk. If you need to count to 10, feel your feet on the floor to ground yourself, doodle, whatever you need to do. I just invite you to take care of yourself, because this is the type of training that can be uncomfortable, but it is so necessary. So the question I often ask my audience when I'm doing my day-long training, I'll ask them, what is trauma? And I'll see the wheels start to turn, and people kind of thinking, And we come up with, a lot of times we'll say, a bad thing that happened to somebody or a life-changing event, and all of those things are accurate. But when we start to really get into the meat of what is trauma, it literally means it's a wound. The Greek word for trauma means wound, and we know that physical wounds require time and the proper treatment to heal properly. I think all of us would agree, and that's just common sense. But when we look at psychological wounding, which is just as significant and leaves very serious scars, we don't often, in the systems that we've created to help people, we don't take into account that they need time and they need the proper care to heal from that trauma. It's one thing to treat trauma or trauma symptoms like post-traumatic stress. It's another thing, though, to actually heal from it and live a life of recovery. So we need to look at that and remember that the systems that we've created need to slow down and meet people where they're at, and realize, if we're looking through that trauma lens, that there's a good chance the person sitting in front of us has had a significant trauma history, and let's treat them accordingly. So it literally means a wound. Traumatic events are external. They tend to happen outside of us, but they quickly become incorporated into our brains. And as I said at the outset, Judith Herman calls it the disease of disconnection. if I come from a trauma background, a lot of adversity in my growing up years, I have a very different idea of what relationship looks like. And I have a very limited skill set as to how to form healthy relationships. So my relationships will tend to be chaotic. They tend to recreate the trauma history. And we can sometimes see that in our clients and the people that we're working with. If we hear their life story, we see this repeating pattern of chaotic relationships or violence. And we just have to go back and wonder, where did all that start? Oftentimes it's because of the way that they were raised and the experiences that they had. Trauma creates lasting adverse effects in a person's physical, social, emotional, and spiritual well-being. It really affects every part of our being, and it is very subjective. My mom was in a bad car wreck when she was 15 with 3 of her best friends in the 1940s, and nobody was hurt physically in that accident badly, but of those 4 young ladies, my mom was the only one who never ever got her driver's license from that point on to the end of her life, because I think her being in a car was such a trigger for her and so uncomfortable that she could never get behind the wheel and drive herself. Trauma lives in the body. The body does remember, and I hear stories a lot about people that will take up yoga. And yoga is a wonderful way to treat trauma and to deal with it. And I often hear stories of yoga students who will be doing these different poses, and they begin to weep uncontrollably. And they're alarmed by that. They're scared by that because they're not sure what's going on. And I've had yoga instructors come up to me during a training and say at the break time, "Yes, Scott, I've seen that. And I wasn't sure what was going on, so thank you for sharing that." Because what we know now is that trauma does live in the body, and the body remembers all of the experiences that it's had. And so we need to be mindful of that. I mentioned how it interferes with relationships, so I won't say more on that. But the other piece of this that's so important is that trauma is a lot more common than you think. When we bother to screen and assess for trauma, we are alarmed at how prevalent it is. So why are so many people talking about trauma? Well, I think that there's this increasing, people with trauma with lived experience are feeling like they have permission to share their stories and disclose what's happened to them, and they're kind of pushing back against that stigma, that feeling of shame that I don't talk about what happened. That's very difficult, but when other trauma survivors hear of another survivor telling their story and they're thinking, man, can I relate to that? My goodness, that sounds so familiar. That gives permission for the rest of us to share our stories. And because more and more people are talking about it, and organizations are beginning to screen and assess for trauma now, again, we're very much alarmed at how prevalent this is. And we now know the science is at the point in 2019 where we can see that trauma can be passed from one generation to the other through the genetic code. We've seen that with Holocaust survivors, with Native Americans, African Americans. We can see that the offspring of those parents who were exposed to a major traumatic event are exhibiting signs of post-traumatic stress, even when they themselves had not been a part of that. But because the science is there and we now understand that there's a lot of truth to the fact that ACEs, adversity in childhood, and trauma can affect our health, we're creating services now, service arrays that take the trauma into account. We start there rather than gathering all this information about a client or a consumer about their life, but we just sort of skip over the trauma part, or we don't even want to go there. And unfortunately, I've had helpers of my vintage, I'm almost 60, who've worked in behavioral health for many years, and they'll say to me kind of on the fly, Scott, I don't really want to go there and open that can of worms, that being trauma, because they're a bit intimidated by having that conversation. So we really need to be prepared to go there and have folks share their stories. So that there are services now that take that into account. And then there's the hope part. How do we give people hope? Well, I like to talk about Father Gregory Boyle, who looks like Santa Claus. I came upon this lovely man when I was doing my research when I first took this job over at DHS, and I was watching one of his conference webinars, and he was talking about these men and women who right outside of he's a Jesuit priest who lives in Los Angeles, and his parish sits at a place where there's a lot of gang activity. And he was very heartbroken to see so many young men and women killing themselves on the streets who were part of these violent gangs. And Father Boyle said that, he saw in the eyes of these young men and women a lethal absence of hope. And all these young men and women, all they were trying to do, folks, is trying to find relationship with each other. and they were forming these family surrogates that were based on violence, but they felt a sense of belonging and connection, because one thing we do know as human beings, we are wired to be in relationship and in connection with each other. And if we don't have that, if that's taken from us at a very young age, or if we don't have it at any part of our life, we can literally die. And we've heard stories of a couple that have been married for 50, 60, 70 years, and one mate dies, the other one follows quickly behind because they feel like they can't go on without that person. We are so tied in to be in these caring, loving relationships with each other. And that's one thing that Father Boyle did when he created Homeboy Industries. And these men on this screen here, they all come from, I would guess, rival gangs, but they have on a Homeboy Industries t-shirt which says, "Jobs, not jails." And what he does is he loves these young men and women unconditionally, and he gives them a job skill. And they're forced to work together. And he'll tell stories in some of his TED Talks where he's had two men that will be standing side by side who came from rival gangs, and they are, not real chummy with each other at the beginning, but then as time went on, they discover their shared humanity, and they find out that they have a lot more in common than they ever dreamed of, and they end up forming these very loving relationships, these brotherly loving relationships with each other. And the cool thing is a lot of these men and women that are part of Homeboy Industries, apart from getting these job skills and learning these relationship skills, they're actually going on and getting married and having families of their own. So Father Boyle is an amazing man. His book, Tattoos on the Heart, was cited at the end of this presentation, but I just encourage you to take a look and hear his story. So there's different types of trauma, and I just wanted to make sure that we're all on the same page with the different types of trauma that we tend to see. The first kind would be called acute trauma. That's trauma that usually has an adult onset, usually a single event. It happens mainly to adults with adequate child development. So that means that they're psychologically put together pretty well, and they can bounce back from this type of trauma fairly easily, fairly quickly, if they have that support system around them. So that's one type of trauma. The other type is called complex trauma, and that is really the opposite, because this happens not to adults, but to children, and usually very small children. They're very innocent and vulnerable among us. Even those with intellectual disabilities, other cognitive disabilities, they are also highly susceptible to this type of trauma. And it's not a single event, but there are multiple events that will happen over time. And that could be days, months, or years. And these events are very highly invasive, they're very interpersonal, so there's a lot of stigma and shame attached. And this child could be told, you're the reason why this thing's happening to you, it's your fault. And so this child at a very young age will wrap this cloak of shame around them. And they'll walk through life wearing that cloak of shame, that where they're less than, they feel that they're worth nothing. And they will grow up into adulthood, and they will grow into the elder years sometimes if they've never received treatment for this, with that cloak of shame wrapped around them. And we need to understand where that may have come from. And part of being trauma-informed, trauma-responsive, is when we do hear those stories that we can gently re-educate folks and give them some reality around their experiences and how that may relate to the way that they've walked through the world. And then we have historical trauma. This is collective, cumulative, kind of psychological wounding that goes across the generations. And normally when we think of historical trauma, we'll think of the Native American population, the African American population, Holocaust survivors, where they've had this horrendous trauma inflicted upon a whole people, a whole culture. And you can look even today, you can see several generations later, the ripple effects of that trauma still being felt. I've been honored to provide training for some of the tribes in Wisconsin, and inevitably they will talk about what happened to mom, dad, auntie, uncle, grandma, grandpa in the boarding schools. And that wounding is still there. So there has to be this collective and cumulative cultural healing that has to happen as well. And then we have sanctuary trauma. This is the type of trauma, to be overt or covert, but it usually happens in places that we would consider to be safe. Our homes, medical facilities, mental health, skilled nursing facilities, foster care, schools, places of worship. If I grew up as a child and my sanctuary was constantly being violated by people being violent and a lot of acting out, what are the chances I'm going to grow up into adulthood in my later years feeling safe with anyone or anything? I will have grown up being very distrustful and just very very much closed off because I'm not going to get in a relationship with people because you're all going to hurt me. So that's a very real type of trauma. And then finally, vicarious trauma is the type of trauma that all of us as healers, as helpers, as first responders are most susceptible to. This is when you're constantly in the presence of other people's pain and misfortune, and you're hearing their stories, and you have a lot of empathy, and you care very deeply for other people. That's why you do what you do. And it begins to wear you down. If you don't have a good self-care plan as a helper, if you really just keep giving, and you have nothing to put back into your vessel, that's where compassion fatigue and burnout can become a very real thing. And unfortunately, in our field, there's a lot of people that are leaving the profession for lots of reasons, but I think chief among them would be the fact that they feel like they can't do it anymore. And that's sad, because I would really like to see work cultures become more resilient, more of a sanctuary to have each other's back, to help each other, to support each other, because only then can you do the best work that you can do. If you feel like you're working in an environment that is very self-fulfilling and very healthy and very collaborative. So the impact of childhood trauma is significant. What we now know is that childhood trauma, it relates to 15 times more likely for people to try to commit suicide, or 4 times more likely to become an alcoholic, or develop a sexually transmitted disease, or inject drugs. I think the big takeaway from this slide is when we bother to look at the power, we look at childhood trauma and we understand its powerful impact, we begin to see that this is really a public health issue. I would even call it a public health crisis, deserving of a public health intervention. So hopefully this will, as people become more aware of the power of this, that we can begin to take this seriously and develop funding sources, funding streams, programs to become more preventative in how we deal with people and how they deal with trauma. We know that at least half of all the adults in the United States have experienced one incident that was considered a major trauma. And in the world of behavioral health, where I come from, over 90% of the consumers' clients that access services have been exposed to a major traumatic event. Most have had multiple exposures. So why would we want to ignore this? This is a big part of their story. It's probably a big part of their clinical makeup, a big part, and it will explain a lot of the behaviors that we see in the different systems of care that we have. So then we have the ACE study, which is the Adverse Childhood Experiences Study. This was a landmark study that came out in 1997, 98. It was designed really by accident. Dr. Vincent Felitti is who I quoted at the beginning of the presentation. He's a medical doctor with the Kaiser Permanente Health System in San Diego, California. He had a weight loss program, and he had a lot of patients who were losing a lot of weight successfully in the program, but then he noticed a fair number were relapsing. And through his investigations, with follow-up interviews with himself and his staff, he found that over half the people that had relapsed and gained a lot of weight back had been the victim of childhood incest, which led him down the road to write a paper kind of exploring that, and that got the attention of another doctor from the Centers for Disease Control, Dr. Rob Anda, and he and Dr. Felitti got together and created the ACE Questionnaire, which is a series of 10 questions asking basic yes or no questions about a person's first 18 years of life. Have you ever been the victim of sexual abuse or physical abuse, or parents divorced or separated, or alcohol or substance use disorder in the home, or a family member is incarcerated? So you answer these questions either yes or no, and you would have an ACE score. And the highest ACE score you could have on the original ACE questionnaire was 10, and that's not good. That would indicate that person's experienced a lot of significant adversity in their life, which has the potential of creating some very significant health problems. So what do we mean by ACEs? Well, I kind of just talked about that, so we just kind of covered a lot of those pieces. But what we found out when they did the original study of 17,400 people, what they did is they had taken the ACE questionnaire and they made it a part of their Kaiser Permanente's health intake questionnaire form that we all fill out when we go see the doctor. Well, they folded those questions in. That's why they were able to get such a large number of people. And they were really stunned at this mainly white, upper middle class population, how high the ACE scores were and how that affected health, because that was not a representative sample of the United States. I mean, it didn't cover flyover country. It didn't cover the Native American populations. It didn't cover the urban areas, except San Diego. So even based on that, there were some very, very significant findings that came out of it. Chief among them, ACEs are common. They can have long-term damaging consequences. It can happen in any family. It does have a cumulative effect. The higher the score, the higher your likelihood of having risk behaviors. And, I look at myself. I have an ACE score of 5. I share that. And I have advanced heart disease. And I don't think I think those two there's a causal relationship. I just do. So I feel like the new life that I'm living since my heart attack 3 years ago is based on the fact that I wasn't doing a good job of taking care of myself, and I was kind of dealing with some things. Even though I was in this job as trauma-informed care coordinator, I hadn't made that connection in my own mind that, gosh, Scott, this is affecting you too. So these are the 10 areas that they looked at for the ACE questionnaire. And you can find the ACE questionnaire anywhere. You can go to the CDC, the Centers for Disease Control, put in the ACE study, and you will find the questionnaire. It's everywhere. It's been interpreted in 26 different languages, and the data has been very, very consistent. We've been gathering data in Wisconsin, just to give an idea. We randomly selected 25,000 Wisconsin residents between 2011 and 2015. Through the Behavioral Risk Factor Survey, we found 57% of Wisconsin residents have one ACE. Emotional abuse tends to lead the pack, followed by physical sexual abuse. And we now know that ACEs are correlated with mental health outcomes, which are less than stellar. Here we're looking at depression, the dark blue, or frequent mental distress. Again, note the relationship between ACE score along the bottom axis and how the percentages of those issues go up with each ACE score increasing. Smoking is also related to this. What we know is that people who come from a lot of adversity in their early years tend to gravitate towards nicotine, because nicotine is a great regulator to help us if we're in fight, flight, or freeze. If we're in toxic stress situations, that calms us down. Both my parents started smoking at a young age. Both of them, if I were to give them the ACE questionnaire, would have scored very high, very common, and both of them died of smoking-related issues. My mom died of a stroke. My dad died of emphysema. So I've seen it firsthand. It's a lifespan issue. ACEs really impact us across the whole lifespan, and not just it affects us neurologically, the way our brain is wired, biologically, our health, our psychology, how we adopt, how we work socially, and our overall mortality. We know that if you have an ACE score of 6 or more, you tend to have a lifespan that's 20 years less than those who don't. ACEs are beginning to be understood a little bit. We're expanding the knowledge of ACEs. We're looking at adverse childhood experiences, those things that happen in the home. But also, we're now understanding that as adversity happens outside of the home, right? So we have poverty, discrimination, community disruption, poor housing, violence outside the home. All of these things are also adverse events that can affect our overall health and well-being. Trauma disrupts our neurodevelopment, as I mentioned. A person experiences trauma, and so they have a traumatic event that happens to them. Their brain and body become overwhelmed. The nervous system is unable to return to equilibrium. And for most of us, if we have a major traumatic incident, we can come back to baseline and calm down fairly quickly. But for some, their systems have been compromised such that their bodies are unable to come back to equilibrium. So they're finding it very difficult. They stay in this heightened state of fight, flight, or freeze, which is what I spent most of my childhood in when I was growing up, thus the ulcer and the wear and tear on my body over the years. If the trauma goes untreated, for a lot of folks it does because they don't make that connection, the person stays stuck in this stress response mode, post-traumatic stress symptoms. So they have a lot of maybe dissociation or flashbacks or nightmares and just constantly living in this hypervigilance. If those cues continue, and they will, the triggers will continue, and it could be anything that will set somebody off. In fact, a person's fight, flight, or freeze system can get so sensitive that people will perceive dangers and threats when they're not really there. But they have been so conditioned over their lifetime that they'll just react from a state of fear, and they will just constantly be getting this fight, flight, or freeze response. So they'll constantly live in that state. Our brains develop in a very, very sequential way, and every developmental stage depends on the previous stage. Usually the brain develops from the bottom up and from the back to the front, in utero. But trauma and those powerful hormones that are released during fight, flight, or freeze, like cortisol or adrenaline, they disrupt the chemistry of the brain and the body, and it can really predispose people to alcohol and drug use, eating disorders, other behaviors, and other mental health problems. And when trauma occurs in childhood, it can have lasting effects on the brain that we'll see in somebody going through the rest of their life. In times of stress, we regress. In other words, if I'm in fight, flight, or freeze, my ability to think logically goes away. And for all of us, that's true. If you've ever tried to talk to somebody who is in fight, flight, or freeze, you can't speak logically to them, can you? They're not in that space. Their body is thinking there's a threat. They either need to run from that threat, fight it, or sometimes they'll just lock up and freeze. But if we understand that, then we also know that there's ways that we can help them calm down and give them tools in their toolbox to help them self-soothe and to ground so that neocortex comes back online, that executive functioning can return so we can problem solve and we can have conversations. So this Triune brain model is a very creative way of describing the 3 levels of the brain. So we have the reptilian brain, which is our most primitive part of our brain that deals with instinct and survival. So our heart rate, our breathing tends to come from that part of our brain, near the brain stem. The limbic system is the emotional part of our brain. That's where trauma will hit that part of the brain and will get stuck there. And if somebody does not receive treatment and healing from their trauma, that limbic system gets hijacked over and over and over again by perceived threats. And so that limbic system is constantly being activated. The person goes into fight, flight, or freeze. Neocortex goes offline, and they kind of live their life in this state of terminal fear and terror because that's where they are. So the neocortex needs to be engaged because that's where our higher thinking skills are. And that can't be engaged unless the person is learning how to self-soothe and how to calm down. So this is a PET scan. The brain on the left is a healthy brain, and you'll see the first thing you'll notice is a lot of red and orange activity, yellow activity, and that's all healthy brain activity. That's what you want to see in an 8-year-old boy. The brain on the right is a PET scan of a little boy that's a Romanian orphan. And what we know about Romanian orphanages, based on the Bucharest study, is that these children are born, they're institutionalized, but there's no give and take with a caregiver. They're just kind of left in a room by themselves. Their basic physical needs are provided for, but they don't have any relationship. They have no connectivity to another person. You can see how damaging that is to the brain. Look at the absence of red and yellow activity. What you see is the part that's red is at the bottom of that abused brain, and that's where the amygdala is. That's the smoke detector in the brain that is overdeveloped in people that have suffered from trauma, because that part of the brain gets all the attention. So trauma, adversity in childhood, in this case neglect, can create brain damage. This is another graphic illustration of a 3-year-old boy, not a boy, a 3-year-old child. On the left is a normal brain scan. You can see what that gray matter would look like from a size and density standpoint. Take that different 3-year-old, but this 3-year-old has suffered extreme neglect. You can see a marked difference in the size of that brain. So that child is already at a disadvantage. And so they can go into our schools, into our systems of care, and if we don't understand their story of where they come from, we're going to see behaviors that we may be tending to wanting to label, like ADHD or on the spectrum or opposition defiant disorder, when in fact they're only operating quite normally, if I would use that word in air quotes, based on their story and their experiences. So we have to be mindful that these folks may be operating from a deficit. Other specific traumatic experiences, well, for this population, they do have traumas. They don't always have to be like big T traumas. They can be small T traumas too, real major things. But the loss of a spouse and peers. Again, we are relational beings, folks, and if they're having a lot of loss, that's hitting them in a point that is where they're very vulnerable. Chronic life-threatening diagnoses. The physiological changes and limitations and disabilities that they face as a normal part of the aging process. The cognitive memory loss. The loss of roles and resources. If somebody who's in retirement and they put great meaning in the work that they did, and now they are retired and they've never really been able to figure out what retirement looks like, and they're just kind of lost. That can be a loss. Increased dependence on caregivers. The question I would ask you is, how does having a trauma history compound these later in life traumas? If you're to look through that trauma lens, maybe, and understand where they've come from, and then putting these on top of what they've already experienced, how would that compound and how would that change the way that you approach these folks? One thing to keep in mind when considering how often older adults face through traumas, any change involves loss. And loss needs to be given the time and space, because it's a trauma, to be grieved, and to be grieved in a way that is going to make sense for that person, because there's no cookbook recipe in how people go through grief. It's different for everybody, but we need to give them that time, space, and permission. So many factors make it difficult, more or less difficult, for elders to deal with traumatic events. It could be their impaired cognition, their mobility, their decreased or unavailable social network, their limited financial situation, any mental or medical problems, history of exposure to extreme traumatic stressors. Again, if they were to happen to have a really high ACE score, substance use disorder, or either language or cultural barriers, all of those play a factor. We need to be mindful of those when we're looking at dealing with elders and looking through that trauma lens. Trauma does pose a threat to the successful aging process because it interferes with relations and productive activity. And contrary to previous assertions of resiliency in older adult populations, there's reasons here to suspect that there's greater vulnerability to emotional difficulties following exposure to trauma in this population, given all I just said in the previous slide. So keep that in mind. So there are some tools to look at, some post-traumatic stress disorder assessments for elders. So we've got a couple things here that you can look at. You can actually Google these and find where they are. But there are tools that I put in here to kind of give you an idea when you want to talk about and think about post-traumatic stress in the elderly population, some tools that are kind of geared towards that population. Also, one of my friends, Gabriella Grant, who lives in California, she gave me permission to share this. She has this brief trauma screen that she created, and it's very relational, but it's like, if you feel safe speaking to me today, and if not, what would help you feel safer? That's one of the pillars of being trauma-informed, by the way, is safety. Do you feel safe at home today? If not, how can we help you feel safer? Do you feel safe at home? Did you feel safe at home as a child? That begins to open the door to having some of these conversations, because a lot of these folks are thinking, nobody's ever asked me this before. But it's relevant, and it's important, and they may have wanted to keep things quiet because they never made the connection that it was something worth talking about. So we have this trauma worldview. The trauma worldview is that no place is safe. My own actions, my own thoughts, my own feelings are unsafe. Other people are unsafe. I have no worth and no abilities. I expect crisis, danger, and loss. And that's really the cloak of shame I was talking about earlier, people in their elder years can be wearing that cloak as well. And they never felt that they had permission to take off that cloak or to really look at this in a different way. That's why we need to shift our perspective to become more trauma-informed. The first thing we want to do is do no harm. And the first thing we should do as helpers is just assume that everybody that we interact with has an ACE score of 10, that they have a significant trauma history, and we'll just exercise universal precautions. Let's not hurt them any more than they've already been hurt. You're never going to be wrong, even if they don't have a trauma history. There's nothing that you're never going to be in a bad spot by treating people with care, compassion, empathy, and love. There's just no way you're going to be wrong about that. But the overarching concept would be that trauma must be seen as the expectation, not the exception, especially when we're working in the behavioral health systems, particularly working with the elderly. So the old question, what's wrong with you? That's the medical model. That's what we're all so comfortable with. What are your symptoms? Where does it hurt? What's wrong with you? They say this in schools with kids, with a child acting up. What's wrong with this kid? What's wrong with this child? The better question is, what's happened to them? What's their story? Can we create an environment where the person may feel permission to share their story? And then I like to add, that's the trauma-informed question. And then one I like to add to that is, what's right with you? Because even though your life may seem very chaotic, you would appear to others as quote-unquote dysfunctional or broken, there's a lot more right with you than there is wrong with you, because you're still alive, you're a survivor, you're thriving to some degree, and you're still in the game. So as a helper, I want to be able to look for, listen for those moments when you've had a victory and give that back to you. So the guiding principles around trauma-informed care, Wisconsin, we created our own guiding principles back in 2009. You can see the different bubbles here, but the biggest one is the one in the middle. And this is the most important thing that I would want to leave you with in this training today, is that healing from trauma happens best in healthy relationships. In fact, Vice Admiral Vivek Murthy, he's the former Surgeon General under President Obama, he was a keynote at a conference about 2 years ago, and he had this quote which blew Twitter up, but he said, the oldest medicine in the world is love and compassion. And I thought that was so beautiful and appropriate for what we're talking about today. And so it's really important to put humanity back into human services on every level. Being trauma forms part of that. These are the 5 pillars I was talking about. Culture change rests on these pillars, creating psychological and physical safety. Building in being more trustworthy as a helper, as a system, and having transparency. Giving people choices, giving them a voice. So we're not just dictating to them, because a lot of trauma survivors are so used to people talking at them, down at them, where they feel like they've never had a good interaction or a sharing of what they would want. So that collaboration, the next pillar, is very important, where we collaborate, we partner. I'm not going to assume because I have a degree or degrees that I'm the expert on your life. Let's talk about, let's have you give some feedback as to what you think is going to be most helpful for you in your healing from whatever it is we're talking about. And then empowering them, building them up, being strength-based. So here's an example of a traditional system versus trauma-informed. You've got somebody where an elder isn't fitting in well in an institution, has limited social skills, not making friends, he's isolating. He's not remembering anything. Well, we could just go there and just look at that and move on from that, but I think a trauma-informed question, but what happened to you would be, what happened to this person? Well, have they experienced a significant loss or a transition recently? Or is there any medical condition? Is there a medication interaction? Do they have a trauma history? Do we know their ACE score? Where are they at? Because those things can seriously affect the way they walk through the world. So we want to do what we can to avoid re-traumatizing people, triggering them. Because it can be obvious or not. It can be unintentional, but it's always hurtful, folks. So what is trauma-informed care? Basically, it's a principle-based, those 5 principles I shared, a culture change process. And it acknowledges the pervasiveness of trauma and how it affects people's lives and how they will access services or not, or how they relate to people. It's about being safe for both the participant and the provider. In fact, I love to see trauma-informed workplaces. This is for all of us. It's not just what we do for the elderly population. It's what we do for each other. Creating that safety, that atmosphere of trust. Being collaborative, being strength-based. Hopefully, it's not an intervention to address post-traumatic stress disorder. It's not a type of therapy. And I hope it's not a flavor of the day, that this is a fad that's going to pass away, because treating people with care, compassion, and empathy should not be flavor of the day. It should be our standard operating procedure. And trauma-informed care is not age-limited. We don't just do it for kids. We just don't do it for adults. We don't do it for elders. We do it for everybody across the lifespan. And safety I've talked about, but these are some examples of what it could be: having a calming environment, being welcoming, having appropriate boundaries, having a safe place to talk and share, those types of things. Using compassionate communication, which is person-first language, not diagnosis first language. Using our empathy before our education. Avoid forcing eye contact. Being aware of how close we are to that person when we're talking. If we want to draw closer, we ask permission. Avoid asking too many questions where it sounds like an interrogation. Be more conversational in your approach if you're assessing somebody. If you could get creative in doing that and still get the same information you'd normally get during an assessment, that's awesome. Being strength-based. Again, providing choice when possible. So during emotional times, asking somebody, how can I support you right now? You may not know what to say to that person if you hear a very gut-wrenching, heart-wrenching story. Sometimes all you can say is, how can I support you right now? When the trauma story leaves you speechless, sometimes can you just sit in supportive silence with them? Not react in horror to what you've heard, but just be with them and let them know that you care about them and you're there for them. Being clear about providing information about when, where, by whom services will be provided, because the person may have some cognitive decline. They may have an overcooked limbic system where their limbic brain is driving the bus at that point, and they are not able to take in information that you're sharing in the way you want them to. And then, repeating that information many times if you have to. So responding to people in need, it's a lot about listening, active listening, validating. That must be very hard to have gone through that, or I really marvel at your strength to be able to endure so much, and here you are, you're still here, you're thriving. Normalizing. a lot of times people have normalized their trauma as just strict upbringing, when in fact, no, that was trauma, that's abuse. And just because your dad beat you till he saw blood because you were a tough kid, that may have been the norm back in the 1930s, the 1940s, whenever. But what we know now about trauma and what it does to the brain and the body, that's going to leave a mark, and a very significant mark. Assisting people with grounding techniques, making appropriate referrals, and doing what we can to avoid re-traumatizing folks. And here's some more ideas on validation, just some ideas, things that you can respond to if you hear a story. Because these words, folks, have so much power, because trauma survivors have never most likely had conversations where people have said this to them. They've been judged, they've been ridiculed, they've been thought less of, they feel powerless. So when you share this with them in a heartfelt way, that is manna from heaven. They really, really will take that in. And if they may not trust it at first, but over time, if they see you mean it, that is very, very significant. And for years, we thought about trauma-informed care in age groups. You know, kids, adults, older adults. And I get training requests all the time. Scott, can you come in and help us do TIC with women, with kids, with older adults? It's all the same. We're all human beings. We've all had experiences from cradle to grave. And we really look at trauma-informed care across the lifespan. And hopefully it will explain a lot of what we see, a lot of their behaviors that it may not, you know, it doesn't excuse their behavior, but it can explain it. So this concept applies to all ages. Being person-centered, being compassionate, being confidential, offering comfort, trust and respect, teaching about recovery concepts, being collaborative, education. All those things apply to every age group. It's not just one group or the other. So I have some more hyperlink things for you to look at to help you in your quest to work more effectively with those with the elderly population, particularly those who have had a significant trauma history. So feel free to look at that. Some other things to look at. Try to be as informational as I can, and I can't believe I got this done in under an hour to leave time for questions. But I do feel like I talked like an auctioneer a couple times. I will admit that. But I guess we can open this up if there are any questions. I'll do the best I can to answer them.
So, operator, do you want to go ahead and just remind people how they can, the options they have for asking the question, and then we'll go to a couple questions that came in on the chat.
Absolutely, thank you. We will now begin the question and answer session. If you have a question, please press star, then 1 on your touch-tone phone. There will be a slight delay before the first question is announced. If you're using speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star, then 1 on your touch-tone phone. Waiting on standby for questions.
Okay, so Scott did get a couple questions, so he's going to address them, and I'll continue to monitor.
Yeah, one question came in. They want to know if there's a connection between personality disorders and trauma. And yes, there is growing evidence that that is the case. I'm thinking of Bessel van der Kolk as a psychiatrist. He wrote a book called The Body Keeps the Score. And in some early research he did with a colleague out east, they looked at the charts of people that had been diagnosed with borderline personality disorder and found that almost 80% of those, he called them patients, that were diagnosed with borderline personality disorder had a very significant trauma history. So I believe, and just in my own experiences and people that I know that have exhibited borderline personality traits, and other personality disorders I think can also be looked at into the same lens. But when you look back at their history, you see a lot of uneven and chaotic parenting going on with these people, and they grew up with a very fractured sense of self. They have a very uneven way of dealing with people, like borderline personality disorder. Behaviors are very black and white. A lot of I love you, I hate you. There's no middle ground. So yes, there is a connection. It's growing, but we need more research. I think that we're just now getting to the point in the trauma research where researchers are beginning to take this seriously. The ACE study was originally thought of as junk science in 1997. This came from Dr. Anda when I was at one of his conferences. But now we've had some longitudinal studies that have gone on beyond that 1997 release. And we're seeing that there is definitely a lot of evidence to support that trauma does affect a lot of what affects us psychologically as well as physically. In fact, I have a good friend who lives with schizophrenia, he told me, Scott, if there was no trauma, the DSM-5 would be the size of a pamphlet.
Are we back in the call, operator?
And Tony, you are now back connected to the call.
Okay, all right. So sorry for that. I'm not quite sure what went on, and I know that we lost some sound. Scott has to, unfortunately, get going to do another training, I would imagine.
Yep.
I can't email the PowerPoint to all of the participants, but what I will do is I will send it out to each of the grade 8. I'll send it to the grade 8 so that they all have it, that they can share with all of their constituents. And then we will make sure on our the LSQIN for Wisconsin, Michigan, and Minnesota that also gets posted so that people should have access to it. And again, once the recording has been completed, that will go on the LSQIN website, and again, I will send it out to all of our grade 8 partners so that everyone should be able to have access to both the slides or the PowerPoint slides and the presentation. All right, so I think given that, then thank you so much for attending today. And again, if you want some of those resources that we created here, go ahead and email me at tkettner, Kettner, at metastar, metastar.com, and I can share the link with you in addition to some other resources. So thanks very much and have a good day. Thank you, operator.
Thank you so much. Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.